Good afternoon to everybody. My name is Emiliano Ferrari, and this afternoon we will spend together 1 hour talking about the evolution of the OT Equator, starting from an overdenture attachment to arrive to be an abutment for fixed rehabilitation. For people of you who knows Rhein83 factory, you know that this is a factory who product for a long time element for the retention of removable rehabilitation. And the element especially used was the sphere. Because the sphere give to Rhein83 the option, the opportunity to introduce the concept of attachment working by retention and not friction. So using a sphere attachment with a plastic material for the female, we have a lot of benefit respect the using of attachment who work by friction, so metal to metal. The sphere was declinated in a lot of solution with different dimension for extracoronal attachment or for overdenture attachment. And with that, we can have a solution like this using direct post or indirect casted post. It depends on the solution you want to choose for your patients, the life expectancy of the element. So a lot of evaluation that you can do before starting the treatment plan, but you can use this kind of attachment, the spherical attachment, for a lot of solutions. And in that way, we can obtain a lot of good results. As I told you, we had different dimensions of the sphere. The bigger diameter of the sphere gives us the option to have more retention. So the first evolution was the transformation from a sphere to a new attachment who is called equator. The equator is an attachment with the same retentive area of the sphere, so maintaining the same retentive area under the equator, but cutting the head. So on that way, we can save a lot of space, and you know that save space in prosthetic world is something really important. So the first transformation was changing the shape of the attachment to have an element for the retention of removable rehabilitation, saving space. But another particularity of the equator is that at his internal part, there's a thread. So for that reason, you can use the equator with the external surface as an element for the retention of direct retention of overdenture. But you can also screw something on the head of the equator. And that way, we have an element, we have an abutment that can be declinated in different way for different treatment plane. You can use it for removable solution, direct retention, removable solution with bar, or, and we will talk about that today, for fixed rehabilitation. So you can see a picture in which the equator are used for the direct retention of an overdenture with direct pin cemented on natural teeth. And that's the first and easier solution. Same things can be done using implant. So you can put implant whenever you don't have enough remaining natural teeth and do the same things using the implant. The evolution of this prosthetic project is to splint the implant with a bar. So on that way, you can have removable rehabilitation, not only implant retained, but also implant supported. So the support in the direct rehabilitation is done by the soft tissue. On that way, you can screw a bar on the head of the equator, and and you can have not only retention, but your implant, but only the help to maintain rigidity in the solution. This is the first case in which we use the threaded parts of the equator, because our bar are screwed on the equator, not only directly on the head of the hip. There's a lot of benefit in this kind of solution because it's easier to build a passive bar, and it's easier to obtain good results. But what we want to talk today is the opportunity to realize fixed rehabilitation directly on the head of the equator. And this project is called OT Bridge, from the name of the attachment that is called OT Equator. OT Bridge is not something brand new because is on the market for something like 20 years. So it's something that we are sure that works very well. There's a lot of scientific work to testimony the good results, the good work of this kind of rehabilitation. So you don't have to intend something like a brand new solution. It's something that works very well. And today we have a lot of experience about that. We have changed a lot of little things to have better results. And I will try to explain you the benefit of these systematics. The idea is to use the equator the same way we use the multi-unit abutment. You know that multi-unit abutment are intermediate abutment that have to be screwed on the head of the implant, and on this abutment you screw your fixed rehabilitation. And the benefit of using the multi-unit abutment are two. First of all, the displacement of the prosthetic connection outside from the gun, because in this case in which you use internal connection, sometimes you have the prosthetic connection in the depth of the soft tissue. So using multi-unit abutment, you can move the connection outside from the soft tissue. But the real benefit is the correction of this parallelism. On that way, you can have one unique direction of insertion of your rehabilitation, also when you put intentionally tilted implant. To have these results, we have two different families of multi-unit abutment. We have angulated one and straight one. They look similar, but they are very different. The only similar things is the prosthetic platform. But the real important difference is that angulated multi-unit abutment are two-piece abutment. You have a body and you have a screw to connect the body of the abutment to your implant. Straight multi-unit abutment are one-piece abutment, and you have to screw it directly on the head of the implant. On that way, you have a lot of benefit because one-piece abutment are stronger respect two-piece abutment and are easier to be used. So the question is it possible working only with straight multi-unit abutment if straight multi-unit abutment are better respect the angulated one? Yes, it's possible using the equator, because you have to intend the equator as a straight multi-unit abutment. One piece, strong multi-unit abutment, easy to be used and to be screwed on the head of the implant. For that reason, you can use this abutment on all implant platforms. It doesn't matter the kind of implant you prefer to use, because you can use the equator always with all the implant platform. But how is it possible to use always straight multi-unit abutment if we have to correct this parallelism? Is it possible changing the shape of the secondary abutment? Because you know that when you use multi-unit abutment, you screw on the head of your multi-unit abutment something like a T-base that is inside the body of your fixed rehabilitation. So the idea was to change the shape of the T-base. And the T-base is named extra grade abutment. Why extra grade? Because the introduction of a widened part in the section of the T-base give us the option to insert our rehabilitation also when we have this parallelism between the hip. Because these widened parts, as you can see in the picture, if positioned in the correct direction, give us the option to go over the disparallelism. But when you introduce a tolerance, like in this case, because enlarging a part of our section means to introduce the introduction of a tolerance. And if we introduce a tolerance, we have the risk of movement between the first and the secondary abutment. So the second element, very important in this solution, is the Seeger. Seeger is that white interrupted ring that you can see in the picture that is used to seal the space between the head of the equator and the section of your extra grade abutment. On that way, you can seal the space and give stability between the connection from your implant, so in this case, the equator, and your prosthesis, so in this case, the extra grade abutment. How it works? It works like this. During the insertion, you have an enlargement of the Seeger that block your T-base to the head of the equator. In this animation, you can see the insertion of the Seeger inside of the T-base of the extra grade abutment and the coupling between our prosthesis and the equator. As you can see, you have an enlargement of the Seeger right now. And it's the only moment in which the Seeger works. He works just when he's enlarged to fit perfectly your extra grade abutment to the head of the equator. On that way, you can preserve the extra space, the extra grade, to have the option of the insertion with tilted implant, but you seal the space and you have perfect fixed connection between the equator and your rehabilitation. Seeger is not something that came from Rhein83, and it doesn't came from dental world. It's something that in mechanics worked for a long, long time, more than a century. In all the engine of our car, we have a lot of Seeger to connect different parts of the engine itself. So we are sure that it works. The only innovation is changing the material on which we have constructed this Seeger. Now you have to believe that it works, because of course it works. So if we will have the option to show you how it works, you will be sure about that. But right now, just believe that it works. So if it works, why you have to use the OT Equator and not the multi-unit abutment? Because I don't know what kind of implant brand you prefer, but all the implant brands have in catalog something like multi-unit abutment. So here we are talking about to change your multi-unit abutment with the OT Equator. And to do that, you have to find some benefit. We have the idea that there's a lot of benefit. Mechanical benefit, biological benefit, aesthetical one, and in the organization of the daily practice. So let's see in deep all this family of benefit. First of all, mechanical one. Use the OT Equator give us the chance to have bigger screw. So the diameter of the screw when you use the OT Equator is 30% bigger respect the user diameter of the multi-unit abutment. On that way, you can screw with higher force of insertion, and you have more stability without the risk of breaking the screw. Second thing is we have a one-piece abutment. And you know that when you use a two-piece abutment, you have the body and a screw. And to insert the screw, you need to create the space. Create the space for the screw inside the body of the multi-unit abutment means to reduce the portion of the thread. So you have to eat a part of the thread to give the space for the insertion. And you have the creation of thin ring. And thin ring are easier to be broken during the chewing, respect the use of a one-piece abutment. So for that reason, we have mechanical benefit using one-piece abutment respect two-piece. Second family of benefit are the biological one. You know that there's a concept that it's called one abutment at one time concept. It means that every time you screw something on the head of your implant, you have the formation of an epithelium junction. This epithelium junction is forming during the flap healing and is no longer violated. But when you violate this sealing, when you unscrew the things you have screwed on the head of the implant. So if you put your implant and use an healing screw, you have the formation of this junctional epithelium during the healing of the flap. But after 3 months, when you took out the screw to take your impression, you broke this epithelium junction. So the concept called one abutment at one time suggests to never remove the abutment screwed on the head of the implant. But how can you do that? The only way to do that is working with an intermediate abutment between the implant and your rehabilitation. This intermediate abutment is screwed before the healing of the flap and no longer violated. But to do that, you have to work in immediate loading because you cannot put your implant and leave the multi-unit abutment free. So, for that reason, this concept usually is intended for cemented rehabilitation or for conical connection. What's the secret of the OT Equator? The secret is that you can use a specific healing cap on the head of your equator, also if you don't work in immediate loading. So you can put your implant and screw this specific kind of healing cap, and on that way you can maintain the sealing. How it works? You can see in this picture we have two implants, same implant. On the left, the healing screw of the brand of the implant. On the right, one equator with the healing cap of the equator system. The difference stays in the position in which you have the formation of this epithelium junction. Because the position influences the option to maintain this junction. As you can see in the picture on the left, you have the neck of the equator and instead you have the healing cap. The formation of the epithelium junction is on the neck of the equator. So when you remove your healing cap, you don't touch the junction that you have formed, and you can maintain the barrier from the bacteria. An interesting thing is that this healing cap is done by two different parts. We have a body and we have a cover screw. And this screw is available in two shapes. A flat screw just to cover your cylinder, or a screw with another equator on the head. So on that way, in some situation, you can move the connection outside from the soft tissue during the healing of the implant. Or in a case like this, if you wanna move the connection outside from the soft tissue without removing your equator to save the biological seal, you can screw this healing cap on the head of your equator, you maintain the biological seal, and you move the retentive area outside from the soft tissue. Another family of benefit are the aesthetical one, and those are very, very important. Why? First of all, because of the height. Because if you imagine that you can correct the same divergency between with an equator or an angulated multi-unit abutment, you have to take in your mind that the equator are so short respect the multi-unit abutment. The equator starts from 0.5 millimeter from internal connection and 2 millimeter for the external connection. It means that if you in anterior zone have to correct a divergency, with the multi-unit abutment, you have a very important metal neck. With the OT equator, you can stay in the depth of the soft tissue because it's easier to cover 0.5 millimeter of metal with the OT equator, respect 4 millimeter with the multi-unit abutment. So the dimension give you the first option to have better aesthetical results. Second secret, and this is very particular things because it's only in these systematics, is the two retention that you have. First of all, you can move little the direction of the hole of the screw with angulated abutment, as you can do always with all your implant with cardanic screw. But the real secret is the snap retention. As I told you, we have a Seeger who give you stability between the equator and the extra-grade abutment. And also we have the screw. But the Seeger give you stability. So in some situation, you can choose to avoid the use of the screw and leave the connection between the equator and the extra-grade just to the Seeger. Not in all the implant, of course, but in some situation, you can choose to leave free 25% of your implant. So in a case like this, in which we have 4 implants, and one of those implants have an emergency in an aesthetical zone, you can realize the rehabilitation without the hole and use this implant, this equator, in a way that we call blind way. So blind way means without the screw. So in this case, we have 4 implant, 4 equator, 4 Seeger, and 3 screw. And the implant free from the screw work just with the Seeger. So that's a very interesting solution because when you have this problem in aesthetical zone, you can avoid the presence of the hole in this anesthetical portion of the rehabilitation. So 25% of the abutment usable in blind ways is our suggestion, but in some situation, we can do something better. So maybe 6 implant with 4 screw and avoid 2 hole for the screw cell. Okay. The last family of benefit are related with the organization of your daily practice. Because here we are talking about an abutment that can be used both for fixed and removable rehabilitation. So if in a treatment plane you have to move from a removable provisional to a fixed final solution, you don't have to change your abutment. You can save your biological seal, save money, save time, using always the same abutment. So in the organization of your daily practice, that's a very interesting benefit. Second reason is that you have the same component for each implant platform. It means that if you use different implant brand, you can have always the same prosthetical platform. And if you face a patient with old implant, you can put new implant of your favorite brand and have always the same prosthetical platform. Last things to keep in mind is that those abutments are available for unknown implant. It means that you can work with unknown implant with the same prosthetical platform of your favorite implant brand. And we will see some clinical cases to better explain this concept and to better explore the kind of benefit is to work with this solution. It doesn't matter if you prefer working analogic way or digital way, because you have the instrument to take your impression in a lot of solution. So analogic way, different kind of transfer, and an analog for your model. But if you prefer work in digital way, are available scan body dedicated to this systematic, so you can scan directly the position of your abutment without unscrewing. So all the components to work in digital world. So you have library, you have the option to design your project working starting from intraoral scan. Nowadays, we realize fixed rehabilitation in digital world, starting from the intraoral scan to the delivery of the final rehabilitation. If you prefer, you can check the precision in analogic way to be sure of the fitting of your final rehabilitation after the intraoral scan, but you have all the instrument to work the way you prefer. So a very important thing is that from a prosthetical point of view, you don't have to change nothing. You don't have to change the kind of material. You don't have to change the workflow. You can work the same way you are used to work with multi-unit abutment, changing with the OT Equator. Now I have chosen some clinical case, 4 clinical case, to go in depth of this benefit of the systematics. First of all, a typical case of dilated loading. So a case of overdenture. This patient want to change from a removable to a fixed solution to improve the benefit of his rehabilitation, starting from here with 2 hold casted attachment on implant that for me are unknown. Those implants are not put by me. So this girl arrived to my office in this situation. I have to improve to put 2 more implants, wait for the healing of the implant because I don't need to go with immediate loading. She had a removable rehabilitation who work, so it doesn't matter going immediate loading, 2 times surgery, waiting for the osseointegration, and during the second surgery, we use the OT Equator as a heating cap. So this day, we screw our equator and we never move it. Now, we have the option to use this equator to retain the provisional, the hold overdenture of the patient. Why? Because in this appointment, I took out the hold attachment to create my new equator. And we will see later in another clinical case what's the workflow to realize equator for unknown abutment. So right now, just understand that at the first step, we are using our equator to retain an overdenture. When we have our new equator for the unknown implant, now we are ready to realize the final fixed rehabilitation. Working same way of you work every day, it doesn't matter what kind of implant we have. The way we took the impression is with customized transferred and customized impression tray, just to reduce the amount of impression material. because on that way, the less impression material you use, the less distortion you have, because you know that the distortion during the impression are more related with the amount of the material respect the kind of material. So that way, we reduce the amount of material and we reduce the distortion. Same appointment, we have a duplicate of the whole denture and we use it to take the interarch relationship. Because if you don't want to change nothing, respect the whole vertical dimension and the whole interarch relationship, you can use a duplicate of the whole denture to save all the information. In this case, we have fixed our duplicate to the new equator and we checked the interarch relationship. So at the first appointment, we take the impression of the implant and we take the interarch relationship. With the working model and this duplicate, we can realize the articulator and we can go to the second appointment in which we will do aesthetical and phonetical trying. And at the same time, we will check the precision of our impression. So we have changed our customized transfer in an acrylic control key. So in the second appointment, we check in mouth the precision of our impression and we check the aesthetical results. If we are happy about this two-step, we have all the information to go to the final rehabilitation. Now you can choose the kind of material, the kind of project you prefer. In this case, we have chosen to work in digital world to realize the rehabilitation with metal structure and commercial teeth. So the design of the metal structure depends from the final volume of the rehabilitation. That's why, first of all, we check in mouth the mouth assembly. We check in mouth the final results of our rehabilitation. And with the technique of subtraction, we design the metal structure in the available space. On that way, we can design our metal bar with all the element of retention for aesthetic material and for the single teeth, respecting the final value. So we don't have surprise to have surfacing of metal parts or to have not enough aesthetical material. That's the project of the bar, because working in digital way, you have also the option to realize a one-piece bar. So there's the option to realize the bar in one piece, or the option to bond the T-base inside your bar. Okay? This is the design of the millet structure, and that's the design of the extra grade details. So how it must be designed to have the better results in the connection between the equator and your bar. And that's our final results. So we can fix with the equator, with the Seeger, and that's our results in mouth. So what is interesting in this first clinical case? I think two things. First of all, we have a rehabilitation with two different brands of implant with the same prosthetic platform. So we don't have to use two different screwdriver, two different transfer, two different analog. We work with the same prosthetic components. And the second interesting thing is that we have used our equator, first of all, for the retention of the provisional, so removable rehabilitation, and at the end, to screw the final rehabilitation, so fixed rehabilitation. Okay, same abutment, two different treatment plane or different solution in the same treatment plane. Another option that we have is work in immediate loading. So immediate loading is something that we use when we don't want to leave our patient with the implant healing without rehabilitation, without the teeth, because maybe we avoid to leave removable rehabilitation on the head of the implant during the healings. So in a case like this, we have to change the upper solution with a new denture and to remove all the hopeless teeth because the desire of the patient is fixed rehabilitation. So first of all, we deliver new removable provisional. Why? Because on that way, we're going to check for a few weeks during the healing of the soft tissue and the bone, we can check the aesthetic, the phonetic, and we can check if that's the good results for our patient. And when we are happy about this, we can duplicate our lower solution to realize this guide. What is this guide? This is something that can be used as a surgical guide, as an RX guide, and as a customized impression tray. And here we have saved all the information related with the provisional, if we are happy about it. So we have lived this provisional in mouth for a few months, maybe 2 months. We have checked if everything is good. And now with this duplicate, we can save all the information starting from now to the final solution. So the surgery is the usual kind of surgery when you realize the immediate loading solution. So what is interest? What's the important things? What does it mean very much? To find a good primary stability for your implant. So the way to find primary stability on your implant doesn't matter. So it depends on the brand of implant you use. It doesn't matter with the OT Equator. So the surgery is the same. And as I told you before, use these systematics never means to change something in your daily practice. So it doesn't change for the surgery. Surgery is the same. You are usual to realize when you work with multi-unit abutment. What is important? Find correct primary stability. So we go a little bit faster to the end of the implant positioning. And when the positioning of the implant is ended, you just have to choose the correct equator. How to choose the correct height of the equator? The same way you do with the multi-unit abutment. So checking the thickness of the soft tissue, taking care about the amount of osteotomy, and taking care about the kind of implant. Because if you use bone level implant, for sure, you need higher OT Equator. If you use tissue level implant, you will need shorter equator. Okay. The important thing is to leave the retentive area of your equator outside from soft tissue. And now you can screw your equator and realize the suture. Now we use our surgical guide as a customized impression tray. So we have created the hole in the same position of the implant, and we use this customized impression tray to fix our transfer with acrylic inside the body. So here we check the correct position of our implant. We realize the hole, we screw the transfer, and we fixed our duplicate with acrylic to the transfer. On that way, we can take at the same time inter-arch relationship, position of the implant, soft tissue profile. We have all the information to go to the end of the rehabilitation, saving all the information related with the provisional. So all the time you spend with the provisional in mouth of your patient is used to save the information to go, first of all, to the fixed provisional and at the end to the final rehabilitation. That's what we call surgical impression. So here we have all the information. And with a single model technique, we realized very easy and very fast provisional, because it means to block our abutment inside the acrylic of the removable provisional with a titanium wire, because it's available abutment to use this titanium wire to have a stronger reinforce inside your provisional in a really easy way. That's the aspect of the soft tissue the day after the surgery, and you can see the heating cap who's saving the working part of the equator, but leave us the option to have the formation of this epithelial junction all around the neck of the OT equator. And that's the delivery of our provision. So another option is working with those kind of abutment for immediate loading, and we can realize a provisional with a little bit stronger reinforce with titanium wire. Another option is realized immediate loading but in guided surgery. What's the benefit of the guided surgery? Of course, that you can have the position of your implant before the surgery time. So you can design your rehabilitation before and fix this rehabilitation, final rehabilitation, at the end of the surgery. In this case, first of all, we have the treatment plan is in the lower jaw. First of all, we have to change the line. So we have to realize a new provisional in the upper jaw and to cut the teeth and deliver a new denture in the lower jaw. As usual, when we are happy about this provisional, we can duplicate and use it same way you have shown in the last clinical cases, but in this case, this duplicate is interesting because we use it to design our surgery. I don't know if you use surgical procedure guided by computer, but the real benefit in this case is the project that you can do before the surgery. You can choose position, dimension, diameter, shape, inclination of your implant before the surgery. And all those factors are not only related with the amount of bone, but are related with the shape of the final rehabilitation. So you can put your implant in a position who is perfectly according the shape of your final rehabilitation, and you don't have surprise in the emergency hole of your screw. So in this case, that the final project, 6 implant, all the emergency, we have a lot of bone. Of course, it was an easy case, but we have implant all in the natural bone and with good prosthetical emergency. So now, before the surgery, we have the position of our implant. So at the same time we print the surgical guide, we can also design our final rehabilitation. Why final rehabilitation? Because we can design a stronger metal structure respecting the position of the implant. Of course, we don't want to screw directly in mouth after the surgery. We want to bond it on our T-base. So what we need a tolerance, we need a little space all around our T-base, the attended position of our T-base. We leave the space to cement in mouth. So that's the provisional, the millet bar and provisional aesthetical parts. That's the finishing, and the day of the surgery, we have our rehabilitation, ready to be bound in mouth. So day of the surgery, we have the surgical template, our rehabilitation, we have the equator of the correct height, because the difference between freehand surgery and guided surgery is that we can choose the height of our equator in the guided surgery because we can check the thickness of the soft tissue using the software. We have also an acrylic guide to help us in the correct positioning of the abutment extrograde. So that's the surgery. It's very boring, the guided surgery. You can see nothing because everything is covered by the surgical guide. So we go to the end of the surgery at the moment in which we use our equator. So now we screw the equator. As you can see, you can screw it also using the micromotor. So you can check the insertion torque. Now, using our acrylic guide, we fixed the extrograde abutment in the correct position, and we check if the hole fitting good with our rehabilitation. If we have no interference, the game is done. We just have to bond our extrograde abutment to the final rehabilitation. So you can choose the material you prefer. In this case, we had acrylic, waiting for the curing, removing the screw, and we just have to finish our rehabilitation. So few minutes after the surgery, to block the abutment, insertion of the cigar, and we can deliver our promotion. Here you see pink cigar because we have two different color of cigar, provisional one, so softer are pink, and final, so stronger. On that way, few minutes after the end of the surgery, we can deliver our final rehabilitation. So what's the benefit using equator in guided surgery? The benefit is that if you have to use multi-unit abutment, it's very, very important the correct position of the hex of your implant. And the correct position of the hex is the most difficult things during the surgical, during the surgery realized by guided computer. So in that way, it doesn't matter the position of the implant because you can screw your equator or the position you prefer, 360 degrees. Okay, that's why you have a benefit using the OT equator also during also using computed guided surgery. Last short clinical case is the use of the equator for unknown implant. In this case, we have a patient who came to my office in this situation without the specification of the implant, so she doesn't know what brand of implant she had in mouth, and she also have a broken screw inside one implant. So we have to solve two problems. First of all, to recognize the implant. Second, to remove the screw. To recognize the implant, it's not important because we can realize customized abutment on the head of all implants. What we have to do, if you have something screwed on the head of the implant, in this case, the patient having in his pocket the whole teeth with abutment, you have to take this abutment, send it to the Rhein83 factory. They can have a copy and give you a brand new customized abutment OT equator who fit perfectly with your implant. If you don't have this lucky, so if you don't have nothing screwed on the end of the implant, you have to take an impression of the internal part of the implant in which you can see the screw and the implant connection. Rhein83 factory can copy starting from this implant and realize the customized abutment. So right now, we have our new abutment who fit with the implant, and we just have to remove the screw. For that is available a disposable who is called Broken Through Extractor Kit, who is realized specifically for all implant brand. And with this extractor kit, you can remove the fragment from the space inside your implant and be free to screw your equator. So starting from an awful situation with a non-implant and broken fragment screw inside the body of the implant, now we can work with free implant, screwing on the head our equator. Now we will work the same way you work with your favorite implant brand. It doesn't matter what kind of implant. So in this case, digital way, intraoral scan, design printing model because we prefer zirconia with ceramic. So that's the final restoration. You can see the body of zirconia on which we cement our T-base. Ceramization, and that's the final results. Here you can see the figure. The position of the extra grade doesn't matter because here we are facing to straight implant. If we have tilted implant, it's very important the position of the straight parts. That must be in the direction of the tilting of the implant. Okay, but if you manage straight implant, it doesn't matter. That's the final results. The option to stay inside the soft tissue because we have short abutment give us the option to conditioning the soft tissue. That's the tissue healing, and that's the final results. So with papilla, because we stay inside the soft tissue, thanks to the dimension of the equator. So starting from an awful situation like this, you can deliver fixed screwed rehabilitation on unknown implant. And that's the only way to do that. If you face really unknown implant, so if it's impossible to recognize your implant, the only way to realize fixed screw rehabilitation is using OT Equator. Why? Because it's possible to customize the equator also for unknown. Okay, so we have seen different clinical cases of delayed loading, immediate loading with guided surgery, and a little case of implant unknown to explore all the opportunity that you have working with this abutment and different respect the multi-unit one. Okay. I hope everything is clear. That's the end of the lecture. If you have some question, we can spend together also a few minutes, or you can contact me or Rhein83 Factor as you prefer to have the answer for every question. Thank you very much.
Amy, we have a question, which is, how do you make impression for unknown implants? What material do you use?
To take the impression?
Yes.
What you prefer, not acrylic, but polyether or silicone, what you prefer, it doesn't matter. It must be a strong material, but the material you use to take the impression of natural teeth, it's perfect.
Another one, how did you retrieve the broken screw?
How?
Yes.
Okay, with that instrument, which is called broken screw extractor kit, you can find the video to better understand how it works, also on the Rhein83 website. But just to explain, you have a driver who must be fixed on the head of the implant. For that reason, is not a universal tool. It's dedicated to every single implant. So if you broke a screw inside a brand and diameter of implant, you have to specificate which kind of implant it is and which is the connection. You just have to ask to Rhein83 a kit to remove a broken screw from a Brannemark 4mm diameter. It's very important because it's not a universal tool. So you have this driver who fixes on the head of the implant and a thread who work in the space. The driver is just to maintain your drill in the correct position. The drill work in other clockwise direction, low, round, and take your screw and remove it. Usually, when you have a fragment of a broken screw, it's not easy to remove it because usually when you broke a screw, it's because the screw is unfixed. When you have the problem that it's impossible to remove it, there's a second drill in the kit who work using the same driver, and you will use it with high round to destroy the fragment. Very important is use it in the correct direction, and that's the reason why you need something to maintain the drill straight to don't damage the internal parts of the implant. But it's very easy to understand. There's video on YouTube and also in the website of Rhein83.
Can the equator manage for the tilting 30-degree implant in all on 4 case? So with Rhein83, don't need with an angle new again?
Yeah, you don't need it. You use always straight. You use OT Equator. The important thing is to choose the correct position of the widened parts of the exograde inside the prosthesis. So the technician must understand which is the correct position of the widened parts. And the correct position is in the direction of the disparallelism. So you have implant in this direction, the widened parts must stay here. And that way you can correct disparallelism until 80 degree. We have done work with 80-degree disparallelism between implant using straight multi-unit abutment, so using the OT Equator.
What torque do you generally screw these Rhein83 abutments in at? What's the maximum?
Okay, that's a very interesting question because it's important to use high torque. So it depends on the diameter of the implant, but minimum torque is 25 Newton and you can arrive until 30, 35. It's very important because you will screw your rehabilitation the same direction you screw your equator. So to avoid unscrewing of the equator, it's very important to screw strong. So usually 25, 30 degree for the equator, 15, 20 Newton for the rehabilitation. And 15, 20, it's high torque of screwing respect the multi-unit abutment, because usually the suggestion of the implant brand are 10, 15 degree, because the screw of the multi-unit abutment are really, really thin. So here, using this strong abutment, you can screw stronger your rehabilitation, but you have to screw your equator until 25, 30 degree. Okay.
Sorry, another question.
Yeah.
Do the OT Equator fit all implants, or do you require it to be customized for each implant?
I don't understand. So if are available for all implant?
I think so. I think she means like.
Okay. OT Equator are available for all implant brands. The working parts is always the same, of course. What changes between one and the other is the connection. So for that reason, you have to specificate the brand, the type, and the diameter of implant for who you need your equator. So brand, diameter, and the kind. And you have to choose the height. So you have to check the thickness of the soft tissue, and you can order your equator in 1, 2, 3 millimeter as you prefer, because in the catalog are available starting from 0.5 to 7 millimeter. Okay, and what is important, the height of the equator must be chosen depending from the prosthetical project, because if you work with removable solution, you have to stay outside from the soft tissue. So if you have thickness 5 millimeter, you need at least 6 millimeter equator. If you work with fixed solution, you can stay inside the soft tissue. So you can choose with 5 millimeter soft tissue, also 3 millimeter equator. Okay, but they are available for all implant brands.
Okay, we have message just to thank you. It's like, thanks, Dr. Emiliano Ferrari, for the clear and straightforward presentation. I use the Equator abutment with success for some time for removable and fixed prosthetic. The broken screw kit is a good tool. I use it, but require a certain practice. I even removed the broken screw inside an OT Equator abutment that hold a fixed OT bridge because of too much loading. OT Equator abutment are very good as MUA, and the use of the Seeger ring is optimal. No question, Dan, and thanks again. And then another one, which is, well, just one question. The T-base abutments are available in 2 sizes. What size you suggest to use, straight or angulated?
It depends. We have more than 2 sizes. We have 3 sizes. We have straight one, normal. We have straight one, mini, and we have angulated one. The mini, of course, give you the option to save space. But you have a thinner screw. The angulated one work the same way, give you the option to move the position of your hole until 25 degree, because it's 15 degree angulated and you can move it until 25. So if you have to move for aesthetical reason or for a reason of resistance, because you want to maintain the integrity of the occlusal surface, you can move it, and so you choose to use it. But you have to use different screw and different screwdriver. So in my personal opinion, if it's possible, I prefer to use the straight one, because so that way I have always the same screw. But if you have aesthetical reason, you can use angulated one. It doesn't change nothing. Nothing in resistancy, nothing in usability, nothing. It doesn't change nothing. You only have aesthetical benefit, but you have to use different screw and different screwdriver. Thank you very much. Thank you to everybody. And if you have some question, just send an email to Rhein83 or by myself, no problem. And I'll be happy to give you the answer.